Good morning, everyone, and welcome to the final Cardiac Sciences Grand Rounds of this season. We take a break in the summer for 2 months, July and August. It is June 24th, and today I have the great pleasure of introducing an external speaker. He's visiting us from the Mayo Clinic in Rochester, Minnesota. Dr. Vasile is a consultant in the Department of Cardiovascular Medicine, as well as in laboratory medicine and pathology in Rochester. He's also an associate professor of medicine and assistant professor of laboratory medicine there. He is a prevention expert in cardiovascular medicine, as well as having a specific interest in lipids. And he's the director and practice chair of the Cardiovascular Health Clinic there. So Dr. Vasile is here to talk to us a little bit about prevention, a little bit about risk factor control. So welcome, Dr. Vasile, and we look forward to your talk.
Thank you very much, Dr. Howard, for the very nice introduction. And thank you, organizers of this Grand Rounds, for inviting me today, giving me a chance to get to know my colleagues from Canada. And actually getting to know Canada, this is my first time in Canada, believe it or not, and I enjoy it very much. You have a beautiful country. So let's get started here. I have no disclosures. So today we're going to talk about biomarkers of cardiovascular risk, and I'm going to focus on biomarkers of atherosclerotic risk. And what I would like to do, I would like to take you all on a trip. And this trip starts in the past, and then I'm going to focus on the present, and then I'm going to show you a glimpse of the future. And I like to start this talk with a quote from Professor Ramazzini, who was a professor at the University of Padova back in the 1700s. University of Padova in Italy is one of the oldest medical schools in the world. And this guy, believe it or not, he was not a cardiologist. He was actually an occupational medicine physician. And in the 1700s, he said, it is much better to prevent than to cure, and so much easier to foresee future harm and avoid it rather than having to get rid of it after have fallen prey. And think about it, this how important prevention is, and how true are his words even today. So the objectives of the talk today are to discuss about the use of ceramide testing for the atherosclerotic risk stratification, and also lipoprotein A as a biomarker of atherosclerotic risk. And this is going to be a case-based presentation. These are all real cases from my recent practice. Nothing is made up here. And I'm going to walk you through. This is the first case, a 52-year-old gentleman that I got the opportunity to see in my clinic. He is active. He works out twice a week by weightlifting and occasional aerobic training. He has no ischemic symptoms. He's not following any sort of diet. He never smoked cigarettes, but he does have a family history of MI at the ages of 48 and 55 in two of his brothers. His BMI is 29. Normal vitals, physical exam is normal, chest x-ray is normal, ECG, sinus bradycardia. Part of his workup included the Bruce protocol treadmill stress test that was negative for ischemia. Seems a little bit deconditioned with a functional aerobic capacity of 88%, normal hemodynamics to peak stress, and his blood work here shows a total cholesterol of 556, HDL 1.5, LDL 3.5, triglycerides 226, non-HDL 406, LPA is in normal range. And understandably, he is concerned about his family history and what is the impact of his family history on his future health. So in addition to lifestyle interventions, what would you recommend? Would you recommend to obtain a coronary calcium scan, a ceramide score, carotid ultrasound, coronary calcium score, and ceramide score? Or would you rather obtain a coronary calcium score, ceramide score, and lipoprotein A? And I'm not going to quiz you. I'm going to give you the answer. For those of you that are very good test takers, I'm going to disappoint you because the correct answer here, and this is not showing very properly here, but really the correct answer is D, coronary calcium score and ceramide score. So this is what I asked, what I requested for this gentleman, and his coronary calcium score was 0, but the ceramide score was 6, and I'll explain what that means. This score placed him at moderately increased cardiovascular risk, signifying that he does have a degree of residual risk. So in a population that is quite diverse, how do we know which are the patients that are at risk? How do we know if patients that are dressed in pink or those in gray or those in blue are at risk of developing cardiovascular events? And I'm going to take you back a little bit to the medical school and discuss a little bit about the, excuse me, atherosclerotic plaque. If you remember, this all starts with the lipid pathway where LDL gets transported into the intima of the vessel, gets oxidized, and then there's inflammation going on as well with inflammatory cells going in. And then there's also the thrombotic pathway involved. So this is a very, very complex structure, very live structure, and very dynamic structure. And we do have some tools in the toolbox to assess the risk of our patients. We have, of course, the cholesterol panel, the lipid panel, and we're using the best recommended calculation for the LDL cholesterol. We do have other tests that we can use. We have imaging tests such as the widespread coronary calcium score. The Agatston method is the most widespread method, but this method also has quite significant limitations. So there's a lack of reproducibility of the test. There are certain calcium densities that are different in different populations. And we expectedly know that when we start the patients on statins, that calcium density will increase in these patients. So there are some limitations, some criticism with these tests as well. In the United States, we use the 10-year pool cohort or ASCVD risk score. It's extensively used to calculate the risk of our patients, and we have this kind of cutoff of if the risk is less than 7.5, then there's no decision, there's no initiation of statin therapy, while if it's more than 7.5, then we generally think about starting statin therapy on these patients. But this risk calculator has also some criticism. There are some studies that show that if you look back at patients that had a heart attack and calculate their ASCVD risk score a year before they got the heart attack, this calculator is able to predict that heart attack in only 50% of the cases. So if you think this is really like gambling or like flip of a coin, it's really a matter of chance. So let's apply this calculator to our patient. You can see here that I plugged in all the numbers, and his risk is really low, is 1.5%. But now let's apply the Framingham calculator, which I believe you use in Canada much more extensively than we do. The ASCVD risk calculator is very, very heavy, weighs very heavy on age. And our gentleman is quite young, he's 52 years old. So understandably so, his risk by the ASCVD risk calculator is low. The ASCVD risk calculator does not take into account the family history, and this is the main concern of our patient. And as you can appreciate here, the risk is quite very different than the risk predicted by the ASCVD risk calculator. Froze here? Or? Okay. So when we are talking about blood biomarkers of atherosclerotic risk, we think about biomarkers that pertain to the lipid pathway, biomarkers that belong to the inflammation pathway, biomarkers that are in between these pathways, and also biomarkers that pertain to the thrombosis pathway. And ceramides are biomarkers that really are very comprehensive and belong to the lipid pathway, inflammation pathway, and thrombosis pathway. From this perspective, I think they're very important in assessing in a comprehensive way the risk of our patients. What are ceramides? They're phospholipids. They're ubiquitously expressed. They're present in all cell membranes. There's more than 1,000 species of ceramides. They accumulate in cells in pathology conditions. When you have caloric excess, hyperlipidemia, inflammation, or ischemia, they tend to accumulate. In many studies, particularly in Northern European populations, and I'm showing here one of these studies, the FINRIS study, some of these ceramide species, particularly the ones that I show here, these 3 species here, have been associated with negative events with MACE, including death, myocardial infarction, and stroke. And so there's this group in Finland that actually developed the ceramide score. It's a calculation of the risk that takes into account those 3 ceramides that have biological interest, and also a 4th ceramide that is used for normalization purposes. And this score is calculated in such a manner that when you report it, is reported as 0 meaning lowest possible cardiovascular risk, and 12 is the highest possible cardiovascular risk. And we did our own study at Mayo Clinic in a cohort of subjects that were followed longitudinally for about 20 years using the ceramide score. And indeed, the ceramide score correlates with these events, including death. And I'm showing here part of sub-analysis of one of these Northern European studies that really show that the ceramide score can predict death and has additive effect to the high sensitivity CRP. The beauty of ceramides is that they're modifiable. So, you know, if you start to exercise, your ceramide score will go down. If you change your diet from a bad diet, you switch to the Mediterranean diet, your ceramide score will go down. Moreover, if you start statin therapy, your ceramide score will go down. And I'm not showing here, but there's also a study from Mayo Clinic that if you start PCSK9 inhibitors, your ceramide score will also go down. So going back to our case, we jointly decided to start a little bit of statin, rosuvastatin 5 milligrams every other day, in addition to lifestyle interventions. So this guy was counseled by both our dietitian and exercise physiologist to change a little bit his lifestyle. And I remind you that his initial LDL was 3.5 and the ceramide score was 6. And I saw him back in about 6 months, and his LDL went down to 2.4 and the ceramide score went down to 2. So in this way, we reduced his overall atherosclerotic risk and also motivated the patient to continue these recommendations, because I showed him the score. Hey, look, your score was 6, placing you at moderately increased risk, and now it went down to 2, placing you at reduced risk. So you're doing the right thing. Your efforts are validated. So keep doing what you're doing at home and keep taking the medications. We are at Mayo Clinic, we use the ceramide 1.0, we call it 1.0 assay. That is exactly the ceramide assay that I described a little bit earlier, but we are going to change that by adding an additional 3 phospholipids to the assay, because there are studies that show that by doing so, you have a better capacity to discriminate for atherosclerotic risk. Also, another advantage is that this will be defaulted to serum, because the current assay is defaulted to plasma. So if you want to add on, we keep the blood of our patients for about 3 days before we discard it, just in case we can do add-ons. But in this case, we cannot do it because tests on plasma are very rare. And so generally, if I want to add a ceramide score, I have to poke the patient again. So it has certain advantages that I think they're going to be very useful for both risk stratification and both for the comfort of our patients. So to put everything together for the ceramide score, it is a robust and very comprehensive biomarker of atherosclerotic risk that has been validated analytically and clinically, both for primary and secondary prevention. It is a reproducible test. It can be used to assess response to interventions, both lifestyle and pharmacologic interventions. It motivates patients to continue the intervention. It has no radiation, very cost effective. And results are very, very easy to interpret by providers. We actually report the ceramide levels, but I think the majority of the providers, they really like the score because it's very, very simple, very easy to interpret, and the patients like that as well. And with this, we're going to change to a little bit of a different case. From my practice, a 58-year-old gentleman. He comes referred from executive medicine. Executive medicine is a subgroup of internal medicine. We get quite a bit of patients referred by them. This is an athlete, and he is referred for routine cardiovascular health assessment. He does have a history of dyslipidemia. His LDL is 147, and he just started rosuvastatin, quite a hefty dose, about a month before I saw him. He had been on atorvastatin before, but could not tolerate it because of leg cramping, and he's still experiencing a degree of leg cramping currently, but he claims that he's taking the medication, and that's reflected in the results of his lipid profile. Part of his workup also included a stress test, and this is a very diverse group here. You can appreciate that this is a very positive stress test with horizontal ST depressions kind of everywhere. Part of his workup also included a coronary calcium scan. You can appreciate very dense calcifications in the LAD, in the right coronary artery. This is quantified at 830 agates on 99th percentile. And with this information, I had to send the patient to the cath lab. He has disease in the mid LAD, mid RCA, distal RCA, but also he has very serious disease, proximal LAD, mid LAD. So quite significant disease that I thought it's probably surgical disease. So I checked his lipoprotein A, and this came back very elevated at 393 nanomoles per liter, where the cutoff is 75 nanomoles per liter. And I underlined he has no smoking history, no family history of premature atherosclerotic events in first-degree relatives. His LDL prior to initiating pharmacologic intervention was 354. And so I started this gentleman on PCSK9 inhibitors because he had both dyslipidemia and elevated lipoprotein A, and I thought the drug would target both. And I also referred him to our cardiovascular surgeon to assess his coronary bypass candidacy. And indeed, he was deemed to be a good candidate and then underwent successful 2-vessel cabbage with a lima to the LAD and vein to the OM. All his first-degree relatives were also screened for LPA, and his brother also had an elevated LPA. Now, this gentleman is currently in cardiac rehab, and I think he will finish it in a couple of weeks, and then I will see him back, and I will retest his lipoprotein A. So what is lipoprotein A? Many things have been said about lipoprotein A, particularly in the past year, and particularly in the US, like the new bad cholesterol, a new biomarker, but truly this is not a new biomarker. The cardiovascular risk associated with lipoprotein A had been described about 30 years ago. What is lipoprotein A? It belongs to the ApoB family of lipoprotein, and it is an LDL particle with its ApoB protein linked by a disulfide bridge to ApoA, and this becomes important from a therapeutic perspective. The plasma concentrations highly correlate with ApoA production, and it is associated with MI, stroke, also associated with the most common valvular disease on the Western Hemisphere with aortic stenosis. It has been labeled as the most pro-atherogenic lipoprotein A, and it does have additive value to the LDL cholesterol. So to put everything together, we're not, molecular biologists here, but lipoprotein A has two components. One of these components binds LDL, transports that LDL, and deposits the LDL in the intima of the vessels. The other component has structural homology with plasminogen, and in experimental models, it inhibits fibrinolysis, and it's a very pro-thrombotic component. And so it is not a surprise that with these properties, many studies have shown that it does associate independently with atherosclerotic cardiovascular events. And I'm presenting here one of the initial studies, which is still a very important seminal study from Dr. Tsimica's group that really showed the linear association of lipoprotein A level with these events. In other words, the higher the level, the higher probability of these events. It does associate with aortic stenosis, as I mentioned. It has a strong genetic component. We know that about 1 in 5 individuals walking on the street have this biomarker elevated. In the United States, we don't have very good guidelines for screening for lipoprotein A. And then there's quite a bit of issues with lipoprotein A testing as well, in addition to the screening. As you can appreciate here, this is the same study from Dr. Tsimica's. Blown up here is this picture that really shows that the risk really starts to increase at a value of 30 milligrams per deciliter, right? And so we know that there's 2 assays worldwide, the metric assay in milligrams per deciliter, and then the molar assay in nanomoles per liter. So we know that the risk starts to increase at these values. But if you look at the American Heart Association, American College of Cardiology guidelines, they endorse this risk at higher values, at 50 milligrams per deciliter and 125 nanomoles per liter. So that poses quite a bit of a problem, because there is this gray area in between these values. So how should labs report abnormal values? Which one is abnormal value? To make things even more complicated, there are different cutoff values for different ethnic groups. And so this is a graphic description of what I just said. There is, if you're in the green area, you're in the normal values for LPA. If you're in the red area, they're significantly elevated, but there's quite a significant number of subjects that will be in this gray area. From a lab perspective, the measurements are not standardized or harmonized between the 2 assays, again, the molar assay and the metric assay, because there's an isoform-dependent bias. We all have 2 isoforms that are circulating, and these isoforms are detected differently by different assays. The molar assay has less inaccuracy than the metric assay, so this is the one that we generally recommend. In fact, we did change the metric assay that we had at Mayo Clinic about 3 years ago. We changed it to the molar assay, trying to minimize this inaccuracy. And we do not do adjustments for age, sex, ethnicity, or other comorbidities, but maybe we should. And again, we know that the risk starts to increase at values of 30 milligrams per deciliter or 75 nanomoles per liter, but the guidelines recommend, or guidelines endorse risk at higher values. Very, very recently at the Brussels Declaration back in a couple of months ago in March 2025, this is a very interesting meeting where they came up with a formula where you can actually plug in the metric value of lipoprotein A and kind of get a number for the molar value for lipoprotein A, which is sometimes useful, particularly if you have a patient that's referred from outside that comes with a value of lipoprotein A in the metric system. But really, I think what I would recommend, I'm not sure what sort of assay you're using here, but if you're using the molar assay, then I would recommend to stick to that and obtain the lipoprotein A again, even if you do have the value in metric, in milligrams per deciliter, just to avoid the degree of inaccuracy associated with that. I'm showing here a study that was done in the MESA cohort that really shows the additive effect of lipoprotein A. And as you can appreciate here, depending on what quartile you're looking at, you can see that the numbers are not trivial. The risk, the additive risk of lipoprotein A is quite significant. Another excellent study, I think, that comes from the UK Biobank, they looked at this biobank and they applied the ASCVD risk calculator, the 10-year pooled cohort calculator, to calculate their risk. And then they came up with a formula where you can plug in that risk and the lipoprotein A expressed in nanomoles per liter. And just as an example here, if the ASCVD risk calculator was initially 10% in the updated formula, which is really the formula here, with a lipoprotein A of 250 nanomoles per liter, really the risk increases from 10% to 17%. So quite a significant jump. So let's go back to our patient. Applying the ASCVD risk calculator in this gentleman renders a risk of only 2.1%. So he's in that 50% that could not predict the bad event. Now he's status post CABG. But if we apply this enhanced formula here, you can appreciate that his risk really is now more realistic. It's about 18%. So this is something that I encourage everybody to use in their clinical practice, not only to assess the patient's risk, but also to show the patient the more realistic risk. So who should we screen for lipoprotein A? Our American Heart Association, American College of Cardiology, recommends screening for patients with familiar hypercholesterolemia with a 2A level of confidence. So universal screening is not endorsed currently by these societies. The National Lipid Association now recommends universal screening, and they also recommend a potential role for repeat testing. The Europeans and you guys recommend universal screening, one lifetime testing. I'm not sure how well it's implemented. I was discussing with some colleagues in Europe, and there's variations between different countries in Europe, and even within the same country, there are variations between different regions as far as applying the ESC guidelines. And this is kind of, I put together the slide to show what different guidelines recommend, what different societies recommend. You can appreciate there's differences between continents, difference between countries, and even within the same country, there are quite a bit of differences and quite a bit of heterogeneous recommendations. So who should we really screen? This is a list here. I'm not going to go over this list of patients that, that are at higher risk of having lipoprotein A elevated, particularly in the category of patients with familiar hypercholesterolemia, where there's a cluster of lipoprotein A elevation. But really, I think I encourage everybody to adopt the universal screening. At Mayo Clinic, we screen everybody in the preventive clinic. It's part of the order set, so we cannot see a patient unless they had a lipoprotein A tested as part of their battery of tests for the visit. So let's change gears a little bit, move to a little bit of a more complex case. This is a 64-year-old lady. She is status post kidney and pancreas transplant, and she's already in partial rejection. She's on immunosuppressive therapy, including cyclosporin. She also has dyslipidemia. Her LDL is 3.13, and she's on rosuvastatin 5 milligrams. And she also has a very strong family history of atherosclerotic events in first-degree relatives. Now, if you're trying to prescribe a statin or Zetia or Ceramide to a patient that is on cyclosporin, there's a very, very strong interaction. So you got a big red screen that won't allow you to progress with your prescription because it does interact quite a bit at the cytochrome P450 level. And so this lady is already in partial rejection. So increasing the dose of statin would place her at higher risk of decreasing the dose of cyclosporin. So she would become subtherapeutic. And so the transplant team referred her because she's very high risk. And I checked her lipoprotein A, which was 86 nanomoles per liter. So it is above the cutoff of 75 nanomoles per liter. It is elevated, but not terribly elevated. So really her risk is enhanced by the cyclosporin itself, which prohibits the use of statin. The family history and also the lipoprotein A. But if you look at our American Heart Association, American College of Cardiology guidelines, lipoprotein A is not elevated enough to enhance her risk. Per these guidelines, really her risk would be enhanced if LPA would be more than 125. So she's in that gray area. So I thought we needed a little bit more risk stratification to better refine and understand what her truly risk and have a goal for therapy. So she's really here in this gray area. And I show here a study that we did a couple of years ago. We presented at the European Association of Preventive Cardiology. We looked at patients with coronary artery disease, and all these patients had coronary angiograms, and all these patients had elevated lipoprotein A. The difference is that some of these patients had elevated lipoprotein A mass that transports a low amount of LDL cholesterol, while other category of patients had elevated LPA mass with a high LDL cholesterol contents. And as you can appreciate here, if you have both LPA mass and LPA cholesterol contents elevated, you're going to do much, much worse than if you have only the LPA mass elevated. So this is the test that is available. We can order it clinically. And I used this test for this lady to risk stratify her. And it came back at 12 with normal value is less than 5. Suggesting that the LPA is the more atherogenic type of particle. So I initiated her on Repatha because this agent does not interact with cytochrome P450. There is no drug-drug interaction with cyclosporine. And also because the PCSK9 inhibitors target both LDL cholesterol and also her LPA. And I suspect, coming from a baseline of 86 nanomoles per liter, the PCSK9 inhibitors will be able to bring her LPA in normal range. Of course, we discontinued the statin, which was anyway contraindicated and was a risk of becoming subtherapeutic and enhance her solitary transplant kidney rejection. So how do we treat patients with elevated lipoprotein A? Unfortunately, there is no etiologic treatment to date. Niacin reduces LPA, but there is no survival benefit. Estrogen also reduces LPA, but you can imagine you cannot use estrogen to reduce LPA. We do use apheresis, but we reserve this for very severe cases. We have 2 positive trials, but there are severe complications that can occur with apheresis. So this is a very reserved therapeutic option. So currently, we emphasize lifestyle. We start the majority of these patients on aspirin. There is quite a bit of data with aspirin to mitigate the prothrombotic effect of LPA. And we also start patients on statins or other lipid-lowering agents to decrease their overall risk. Statin therapy, there's not as much data or as abundant data as with aspirin, and there's also some controversial data as well. And one of the most frequently missed recommendations is not to forget to recommend screening of their first-degree relatives. PCSK9 modulators, the PCSK9 inhibitors and the sRNA and inclisiran, they both can reduce lipoprotein A by about 20–25%. So again, our patient with an LPA of 86 probably will become in normal range with evolocumab that I put her on. But lipoprotein A is also associated with other conditions, not only with atherosclerotic events, not only with valvular disease, but also with atrial fibrillation, with aortic aneurysms, with inflammation or unexplained thrombosis, even with heart failure and preeclampsia. So we wanted to look at Mayo Clinic and see how bad we're doing with lipoprotein A testing. And we looked, I think between 2022 and 2023, we picked 1 year and we looked at patients that are at a little bit of a more enhanced risk. We looked at patients that had lipid profiles in that year. And to our shame, we tested less than 1% of those patients for lipoprotein A. And the testing had a sex bias. We tested more men than women. And when lipoprotein A was elevated, there was no impact on management of these patients. We also wanted to see, for which indication we requested lipoprotein A. I think it was for secondary for secondary prevention. In other words, first we waited for that heart attack or stroke to happen, then we tested for lipoprotein A, and if it was elevated, we didn't do much about it. But if you look throughout the years, the volumes of lipoprotein A requests have increased substantially. And I can tell you from experience, because I'm the director of the lab that tests the lipoprotein A this year, the volumes of lipoprotein A have exploded to the point that we can barely keep up with testing. So that's good. So I'm going to take a step back. I told you that I would start to talk a little bit about the past, focus on the present, and now I think it's time to talk about the future. Anybody knows here in the audience who Carl Sagan was? Okay, some people do. Okay, okay. So this guy was not a physician at all. He was an astronomer. In my view, he was a genius. He wrote scientific papers, and at the same time, he also made science fiction movies. And so in the 80s, he said, you have to know the past to understand the present, and then take a glance at the future. And I think the future is quite bright when it comes to lipoprotein A. The National Lipid Association in the United States has come up with a statement last year when now they endorse universal screening for lipoprotein A. Moreover, they admit that yes, there is that risk. They call it the intermediate risk of patients that are in that gray area with values in between the two cutoffs. Importantly, they also came up with an action plan for patients that have elevated lipoprotein A, because we know that one of the reasons for which lipoprotein A is not tested sufficiently is because providers don't know what to do if lipoprotein A is elevated, so then they avoid requesting that test. Another positive fact is that the American Heart Association has initiated this national awareness program back in January 2024. This is a 3-year program. It includes 10 big centers across the US. Mayo Clinic is one of them, and I'm happy to represent it. And it has the aim to spread awareness about lipoprotein A throughout the country, and to get good practices as model for other institutions. It's a very nice program. We get to meet every month. Because we have to be ready, because drugs are coming up. We will have drugs that will target LPA. Currently, there's at least 5 drugs that I'm aware of that are being studied. Some of them have completed phase 3 clinical trials. Some of them are still in phase 2 clinical trials. As far as mechanism of action, some of them are small inhibitor RNAs, other ones are antisense oligonucleotides, and there's even a small molecule inhibitor that prevents that disulfide bond between the two components of lipoprotein A, so it prevents formation of lipoprotein A. The majority of these drugs are infusion drugs, with the exception of the last one here. I'm going to mispronounce it, but muvalaplin is the small molecule inhibitor, and it's an oral medication. Some of these drugs will target both LDL cholesterol and lipoprotein A, while other drugs target only lipoprotein A. And some of these drugs really lower lipoprotein A in a very, very impressive manner, more than 98%. Mayo Clinic is part of was part of the phase 3 clinical trial for some of these drugs, and I got a chance to look at the randomized arm and see levels before, after, and it's quite impressive. From levels of 300, it goes down to undetectable levels. I mean, some of these drugs do a fantastic job, but we do not have yet outcome data. So this is what we're currently waiting for. So to summarize, lipoprotein A bears independent but yet under-recognized risk for atherosclerotic events. About 20% of the population has elevated LPA. Measurement can be challenging. We prefer using molar units if possible. Universal screening is not yet adopted in the US. National Lipid Association recommends universal screening. American Heart Association has started a national awareness program. The LDL cholesterol contents of lipoprotein A can be an important tool that you can use for patients that are in that what I call the gray area, patients with some elevated lipoprotein A, no other risk factors, where you really want to understand how atherogenic the particle of LPA is in order to manage their risk. Currently, we do not have etiologic treatments, but we do emphasize lifestyle. We use aspirin, statins, PCSK9 modulators can reduce LPA to a certain extent, and we do have very promising therapeutic options for lipoprotein A, as I mentioned. And that was it. Thank you very much for your attention. Ready to take your questions, comments.
Thank you very much for that wonderful talk. We will open the floor to questions, and I'll just open up the chat here. Looks like there's a number of things in the chat. So why don't we start with a chat question this week? How do you find the ceramide score adds or fits into goal-directed fashion compared to aggressive ApoB reduction?
A very good question. I think we are talking about two different categories of risk, because the ceramide score, the ceramide species that we use in calculating the score are involved in the lipid pathway, but not only in the lipid pathway, they're also involved in the inflammation pathway and thrombosis pathway. There is some data with ceramides that some of these species that we use in the score can be predictive, for example, of other things. For example, onset of diabetes in a patient with impaired fasting glucose. And this is one of the reasons for which we report not only the score, but also the species, because the VERSE preventive cardiologists will probably look at those ceramide species as well. So this is very different than the ApoB pathway. We're talking about two different types of risk. Does this answer the question?
Jeff.
Yes.
As a follow-up to that, we didn't necessarily see what the discriminatory ability of the ceramide score was on top of a Framingham risk score with family history or a ASVD score with LP(a) addition. Does it add how many patients can have risk reclassification? What's the C statistic, just to know what the impact is in addition to what we already have available?
Yeah, so we looked actually, this is a very good question, very good point. We looked and compared the ceramide score with the ASCVD risk calculator, with the American risk calculator that we use extensively. And I told you that the C statistic for the ASCVD is really about 0.5, and the ceramide is about 0.65. You have to understand that no matter what score you have, whether you're using the Framingham or using the ASCVD or using whatever you're using the score in Europe, there's different platforms, different ways of assessing the score. But we're talking about a very multifactorial condition, right? Coronary artery disease is not like you get COVID because you got the virus and you get pneumonia. It is a very multifactorial. So there's inflammation, thrombosis, there's other pathways, there's LPA, there's hypertension, there's stress, there's sleep. There's so many things that can contribute to coronary artery disease that they will not be a system or a platform that will be able to get a C statistic of 0.8, 0.98 or something like that. There will never be such a thing. And so the ceramide score is a little bit better than the ASCVD risk calculator, to answer your question. I don't think there's data where we actually didn't look to compare the ceramide score with the Framingham score. Yes.
For your talk, thanks. A couple questions. First of all, many of your patients were a little bit on the younger side. Just curious what your approach would be to your 85-year-old patient that comes into clinic in terms of how much of this testing you would do. And then secondly, kind of the unspoken kind of thing hanging over everything is the cost. Like going to case 3, what if your patient couldn't afford Repatha, what your approach would be. And then all these kind of pending lipoprotein A therapies, I suspect will be of the same magnitude of cost as the PCSK9 inhibitors. How do you approach the majority of patients that aren't going to be able to afford these therapies?
Yeah, very good practical question. So for the first question, the 85-year-old, the battery of tests is exactly the same battery of tests. Otherwise they won't be able to be seen by us. But in practice, although I have the results of this test, if I see an 85-year-old lady that has, elevated cholesterol, that has a little bit of an elevated lipoprotein A, but has no family history, she's doing very well from other perspectives. I'm not aggressive with this patient. I won't start to intervene as opposed to somebody who's younger with the same risk factors. They have a higher life expectancy. But what I probably would recommend in the 85-year-old with a little bit of an LPA elevation is to have her first-degree relatives screened, because this will impact more her first-degree relatives than herself. And in my mind, I always think, yes, she does have lipoprotein A elevation, and yes, she does have LDL cholesterol elevation, but maybe these are not the atherogenic types of particles, because she's 85, she made it to 85, she has no personal history of atherosclerotic events. So maybe she does not have a high contents of high dense LDL that is more atherogenic than the LDL cholesterol, and maybe her LPA is not the atherogenic type. So generally, I'm not as aggressive, and my colleague here, Dr. Iftikhar, can tell you that I'm a little bit more aggressive when it comes to practice, as opposed to some of my colleagues, where we're kind of divided into two groups: the more aggressive group and the less aggressive group. And so I'm on the aggressive side, so I want to prevent things. But in this situation, I'm a little bit more lenient. Could you remind me the second question?
The cost issue.
The cost issue of PCSK9 inhibitors. Well, in the United States, we have the insurance companies have certain rules for approving these medications. And some of these rules, for example, are, if you have your patient on statin therapy, maximum tolerated statin therapy, they're not at goal. Or if they tried 2 statins and they're intolerant to statins, they have side effects to statin, then you can go to PCSK9 inhibitors, and generally they approve it. And another thing, if you have, for example, a coronary calcium scan that is more than 100, this number I don't like very much, because you can be 35 years old and have a coronary calcium scan of 2, and then that, but the insurance companies really don't look at the percentiles. They really look at the numbers, strict numbers. So sometimes, for this reason, I try to avoid doing for example, a coronary calcium scan in a younger patient, because I probably don't expect that coronary calcium scan will be 100 and that will be negative on behalf of the insurance company or approval process. Nevertheless, if let's say the insurance company denies the patient for PCSK9 inhibitors, we fight back. We always appeal with them, we write, we have peer-to-peer communication with the insurance company that has a physician representing their company. So, and generally we do win. But yes, you're absolutely right. The costs of PCSK9 inhibitors can be prohibitive. I think if we're talking about Repatha, it's been on the market for 9 years or so, and it's still quite expensive. You have to pay from the pocket. I think it's about $600, $700, $800 a month, but it used to be $7,000 when it came. So, and you're absolutely right. Probably with the new drugs that will be targeting lipoprotein A, the prices will be very, very similar. But as long as these are approved by the FDA, the insurance companies have to comply with that. It is important to understand that the indications for which the FDA approves a medication for it are only the indications that are going to be accepted by the insurance company. So, for example, the example is Repatha, that is approved by the FDA, but is not approved to target lipoprotein A, is approved to target only LDL cholesterol. So If I try to prescribe Repatha on a patient and I put it in my note that I want that drug for LPA reduction, it'll be an auto reject from the insurance company. So have to be a little bit diplomatic.
Questions here? Any real concern regarding the modest increase in LPA with statin therapy?
This is a very good question, a very good topic. Statin therapy increases LPA concentration to a certain extent. It doesn't increase it very much, and we do not believe that, by increasing the LPA by about 10%, this is kind of the range, you actually increase the risk. But what we think is that you actually decrease the overall risk profile of the patient by putting them on a statin and decreasing the LDL cholesterol. There is, to my knowledge, only one or maybe two small studies that have showed negative impact by increasing the LPA with statin therapy. But I think the majority, if you ask any preventive cardiologist, they will tell you that the benefit of statin probably offsets that risk. We know that the statins will not completely offset the risk of lipoprotein A. I have a patient, a young patient, just as an example, a very young patient with an elevated lipoprotein A, probably in the 160s, if I remember correctly, not terribly elevated, but she has terrible, terrible coronary disease. And her LDL is undetectable. So she is both on statin and PCSK9 inhibitors, and she continues to have progression of disease despite the LDL. And so we know that by using statin therapy, by decreasing the LDL, you cannot completely offset the risk of lipoprotein A. But these are really the tools that we have in our hands, and this is how we currently approach our patients. There is more data, as I mentioned, with aspirin, more safety data with aspirin than with statin therapy.
I want to take you back to the ceramide
Yes.
score. How widely used is that outside of the Mayo Clinic? How much does it cost? Who gets it and when?
Very good question. So I think the majority of the tests are ordered by the Mayo Clinic, but we do get quite a bit. I would say about 60% of the volumes of tests are outside tests. This is a test that can be a send-out test. The samples are stable for about 3 days, so they can be shipped. The cost of the test is about $100. And who we do, well, generally we use ceramides for two categories of patients. First of all, for risk stratification, because it gives you, I think, a little bit of better information than, for example, the coronary calcium scan. But also for follow-up purposes, because I always get ceramides at baseline when I first see the patient. And then when the patient returns, 6 months, 1 year, when the patient returns for follow-up, I repeat that test to make sure that they stay on the right track. If you compare that to the imaging test, I cannot, we all get the question, okay, doc, I have coronary calcifications. I'm going to do this and this and this. Can I test, can I rescan in a year or so? So the answer, of course, is no. But with a ceramide score, you can do that. So use it, kind of for all the patients that you would have an indication for a coronary calcium scan. The coronary calcium scan gives you information that the ceramide score cannot give you, right? It gives you information about the calcium burden, location of disease, high risk, low risk of disease. But then the ceramide score, you can get a baseline, you can follow up. So I think.
Okay. Can you use that score more predictive, okay, at an earlier stage and avoid a lot of these other tests? Can this be done, say, in the age of 20, 30, maybe even years younger, and predict your score and avoid some of these other tests that you've done?
Yes, and I think the answer is no. I don't think there is data, published data, but from my practice, I can tell you that really the ceramide score correlates with so many things, including with obesity. Because, you know, obesity, fatty tissue in my mind is, oh, I see fatty tissue, I see inflammation. And when the patient, you know, loses some weight, for example, with these newer drugs that help you lose weight, all the GLP-1 agonists, SGLT2 inhibitors, and you know, the ceramide score goes down. So yes, you can use it for younger patients as well. Can you avoid other tests? That is a very good question. I never thought about that. But I think you can potentially avoid some tests, but you cannot avoid, you know, because, for example, you cannot avoid the lipid panel, get just the ceramide score without the lipid panel, because the lipid panel contains information that is probably included in the ceramide score, but it's not, you know, looking at the ceramide levels in the ceramide score won't predict what your LDL will be. And so for the same thing for LPA and so on. So I don't think.
So it can't help you sort out your reds, your blues, and your.
No. It can give you an idea of the overall risk, but then again, you know, overall, let's say I have hypertension, you have hypertension. Well, my hypertension is probably going to weigh different in my risk than in your case. So, you know, we're probably going to have different ceramide scores. So it can't really go into that type of detail.
And is there a difference in ceramide scores between male and female?
No, there are no differences. Yeah.
We have a couple more in chat. I noticed that you recommended aspirin for patients with elevated LPA. Is there any strong evidence in the lipid literature considering that primary prevention studies given ASA for patients at moderate cardiovascular risk are predominantly negative?
So if I understand correctly, the question is, you know, refers to how we're using aspirin and not necessarily for LPA, but in general to mitigate the cardiovascular risk. And, you know, we used to give aspirin to everybody. You know, if you look 10 years ago, everybody was on aspirin for primary prevention purposes. But we have this a newer study, it's not new anymore, you know, 5-6 years ago, that showed that the risk of bleeding with aspirin is not as trivial as we thought it was. And maybe the cardiovascular benefit of, you know, the low dose aspirin is not as important as we thought it was. So then, what does the medical community do when you have such evidence? From 100% being on aspirin, we switch to 100% on no aspirin. And I'm sure you have the same, you see this over and over in your clinic where patients tell you, yeah, I was on aspirin, now I'm not on aspirin anymore because my primary care provider took me off the aspirin. I think, you know, the correct way to do this is to be somewhere in between. You know, kind of look at the overall risk profile and make a decision whether you start aspirin or not. If you're looking strictly at the guidelines and numbers, you know, if you look at the MESA score or ASCVD risk calculator, you know, the cutoff for initiating aspirin is 10%. I don't really like numbers because, again, these scoring systems, these platforms, they're not entirely accurate at assessing the patient's risk. So really just going by a 10% risk below or above for decision-making for initiating aspirin, I think it's very practical.
Thanks. I will end with one question for Umair. Do you know if ceramide testing is available?
It is available. So it's done here through a private lab. It's about $200, and it takes about a week.
With that, we will close, and I thank Dr. Vasile very much for coming to Calgary.